All right, everyone. We're going to go ahead and get this show on the road. Thank you so much for joining us this afternoon. My name is Blake Henderson. I'm the acting director for the Diffusion of Excellence program. It's really a great honor to be up here to host this event. I'd like to start by telling you a little bit about what brought us here. And essentially, in 2016, the Veterans Healthcare Administration embarked on a journey to identify employee-developed solutions to common issues selecting healthcare and to accelerate their spread across our healthcare system. The goals were to promote a common veteran experience with consistent care quality, to invest in the incredible capacity of our workforce, and to build trust, restore hope, and exceed expectations of those who seek our services. With those goals in mind, the Shark Tank competition was born, and in the last 4 years, VHA employees have submitted 2,267 practices to our employee competition. 4 Shark Tank competitions led to the recognition of 47 gold status practices, which have replicated more than 400 times to over 150 medical centers and impacted more than 100,000 veterans. Now, if you told me several years ago that I would be up on a stage hosting a competition and there'd be a big shark looming behind my back, I would say, oh my gosh, what went wrong? But this shark has actually become a pretty important symbol to me. And to me, what it means is that while we're asking veterans to trust in us and we seek to continuously earn their care, it's also vitally important that our employees choose VA each and every day as a place to innovate. That you all believe that when you contribute excellence to this organization, when you do something great, that it's going to be valued as such, and it's going to be given a platform. And you do have the possibility of replicating it. To me, I see this shark, and it's a symbol of trust. And it's building trust with our workforce that this is a place where you can have an impact. So 1 year ago, another comment I'll make is to us, the Shark Tank competition is just another milestone. We've always seen the Shark Tank as really a vehicle for creating employee-driven process improvement and care quality improvement networks and movements. So 1 year ago, in conjunction with many organizational partners, we began to nationally diffuse 5 gold status practices that demonstrated extremely high impact and the ability to replicate rapidly. So I'd like to take a moment to introduce you to those practices. Pneumonia is the #1 hospital-acquired infection in America. Hospital-acquired pneumonia prevention by engaging nurses, better known as HAPN, demonstrates that a simple, low-cost, nurse-led intervention, teeth brushing, can dramatically reduce the incidence of non-ventilator-associated hospital-acquired pneumonia. Led by VA nurse and researcher Dr. Shannon Monroe of the Salem VA Medical Center, HAPN is now utilized by nurses at 42 medical centers and growing, and has prevented an estimated 268 pneumonia infections and saved 48 veteran lives when compared to baseline. Today, more than 40% of older Americans living in their homes take 5 or more medications, a problem known as polypharmacy. The Vione medication deprescribing gold status practice, created by VA geriatrician Dr. Sarah Batar at the Central Arkansas VA healthcare system, ensures veterans only take the medications they need. Vione has spread to 32 VA healthcare systems, reached almost 54,000 unique veterans, and safely deprescribed more than 116,000 unnecessary medications. Next up, Flow 3. The prescription and fitting process for a prosthetic limb can be lengthy and difficult for both veterans and employees. I'd appreciate if we have the Flow 3 Gold Status Fellows, if you might stand up and join us. Stand up and be recognized. Hey, Jeff. The fellows for the last 2 practices I mentioned are literally evangelizing their practice at an industry conference, and then Dr. Batar with Vione took a cab over to the Washington, D.C. VA Medical Center to, again, evangelize Vione. So that just shows you about the dedication of these folks. So to accelerate prosthetic limb delivery to veterans, VA physiatrist Jeff Heckman of VA Puget Sound Healthcare System and his team developed Flow 3, a software solution that enables process automation for ordering limbs. Flow 3 is available at 25 VA medical centers, continues to scale, and in the last year touched the lives of almost 2,700 veterans with improvements in delivery timeliness of 50% or more. Veterans in rural areas without easy access to regional VA healthcare systems often wait too long to receive wound care services, placing them at increased risk for limb-threatening infections, hospitalizations, and even amputations. Do we have Dr. Baharastani with us today? Telewound, created by Associate Chief Nurse, Wound Care and Research, Dr. Mona Baharastani of Mountain Home VA Medical Center in Tennessee, has spread throughout Vision 15 and positively impacted the lives of over 1,200 veterans, dramatically improving access to care for rural veterans. According to the CDC, opioids were involved in over 47,000 overdose deaths in 2017. The VHA Rapid Naloxone Initiative, developed by Patient Safety Manager Pamela Bellino of VA Boston Healthcare System, saves lives by encouraging VA police to carry intranasal naloxone and the placement of naloxone in AED cabinets. In the summer of 2018, Pam joined forces with VHA's Office of Mental Health and Suicide Prevention and the VA Police to expand the practice's reach, and over the course of 9 months, rapid naloxone spread to 116 VA medical centers, leading to 126 known opioid overdose reversals. I'd like to take a moment to recognize a milestone recently achieved by one of our key partners in this practice. Do we have Dr. Elizabeth Oliva with us today? Please stand up for us. Dr. Oliva runs VA's opioid overdose education and naloxone distribution program, which recently issued naloxone to its 200,000th veteran, leading to over 700 documented overdose reversals. Please join me again in congratulating Dr. Oliva for this milestone. Today, we also have the pleasure of introducing 3 new national diffusion selections, all winners of our last year's competition. Stride, do we have Ashley with us here today? Lack of mobility during hospitalization contributes to complications such as falls, longer hospital stays, and increased risk of readmission. Stride is a proactive inpatient walking program developed and led by Dr. Nikki Hastings of Durham VA Healthcare System, already in place at 18 VA medical centers. Stride gets veterans moving, improves their inpatient experience, and gets them stronger to return home up to 1 day faster, with savings of over $1,700 per patient per stay. Hypertension management via virtual visits. Veterans with hypertension often drive many miles to have their blood pressure checked and recorded at an in-person clinic. Hypertension management via virtual visits uses the VA Video Connect app to offer veterans blood pressure check-ins wherever they choose. This program achieves a 94% satisfaction rate among veterans choosing virtual visits over face-to-face encounters. We have Dr. Carrico representing this practice here today. Thank you, Dr. Carrico. You're apparently all over there. You thought I would learn this by now. So all of this... Shout out to Courtney Frosch, Dr. Carrico's partner here. So all of this work, diffusing employee-driven promising practices, is pretty incredible. But there's just one problem. We understand that there's so much more of this work going on across our healthcare system. We really need to shine a spotlight on all of this work, not just Diffusion of Excellence gold status practices. We know that to truly transform VHA into a learning organization, we have to show the successes and the failures. So with that in mind, today we want to introduce you to the Diffusion Marketplace. The marketplace embraces the principles of market leaders in online commerce and customer experience. The highlights of the marketplace are the individual practice pages. These pages are packed with insights, starting with the story of the practice and its origin. The pages provide detailed information, such as the resource required in terms of FTE or funding, the complexity of change management, and a timeline for implementation. Finally, we also offer lots of sharing tools so you can build up local support at your medical center or VISN, opportunities to connect with key team members, as well as the posting and viewing of comments made by those with practice knowledge. The marketplace map shows you exactly where practices are adopted across our healthcare system. You can easily search by individual practice or even by VISN to see what the facility down the road is implementing or spreading. With the Diffusion Marketplace, we're going to start putting a spotlight on all the incredible work from across VHA. We'll be starting out with 50 practices nominated by a variety of practice partners. The practice partner pages offer an opportunity for individual program offices and VISNs as well as medical centers to showcase their great work. You might ask, how can you get your practice or project featured on the marketplace? It's pretty simple. Right now, we're looking for practices that are adopted in at least 2 or more locations, that are endorsed by a national stakeholder, and that are actively spreading to other locations. So if you would like to nominate your practice to the marketplace, please email us at marketplace@va.gov. We anticipate that the marketplace will be available to all VA employees in January 2020. You can also check it out today in the table across the atrium and tomorrow in the Experience Center. So come check out the marketplace, give it a spin, and give us your feedback. Now, it's time for the Shark Tank competition. Can I get a little hand here? Woo! All right, so we're proud to announce that this is going to be our most exciting year ever. For the first time ever, we've flown in all 15 finalists. They're up here right in front of me. We're also incorporating a popular vote component. So you all in the audience can use the app, the Attendify app, to choose which practice you want to vote for. The practice with the most votes will automatically become a winner. This year we had a record number of practice submissions, 591, and now we're down to the top 15. These 15 practices address priorities including suicide prevention, telehealth, and high reliability transformation. And mostly online, we have about 40 medical center and VISN director sharks who will be bidding on these practices to bring them to their medical center. Now, in terms of how the pitch works, each finalist will give a 2-minute pitch of their presentation, and then we'll be followed by 3 minutes of Q&A by our Q&A moderators. I want to go ahead and welcome up to the stage Matt Crowley. He's an innovation specialist out of Pittsburgh VA Healthcare System. And then next up, we have Devin Harrison. He's Devin's a diffusion specialist with the Diffusion of Excellence. In terms of bidding, the Sharks will have until 10 a.m. tomorrow morning to submit their bids with our online tool. Winning gold status practices will be announced tomorrow afternoon at the end of the Innovation Experience event at 4:30 p.m. Now, in terms of voting, we hope you will have downloaded the Attendify app by now. If not, please get on the Google Play Store or the App Store, download that app. That's how you will go about voting. And then before we transition into our pitches, for a moment, I want you to put yourselves in the shoes of some of our presenters here in front of you. A lot of them have been working on their practices for multiple years. They know there are things that work. They've looked in veterans' eyes, they've looked in the eyes of their colleagues, and they know that these things work. And now their job is to get up here to present to hundreds of coworkers and convince you all that they work. So it's a bit of a daunting task. So what I'm asking you to do now is to help by giving them a rock star welcome. Could you please give them a hand? All right, thank you. So first, we're going to start out with Michael Moats. I would like to welcome Michael Moats from Birmingham VA Medical Center. There you go, sir.
130 Americans die every day from an opioid overdose. and veterans are at least at a twofold risk of this same tragic event. The current clinical models that help reduce patients' reliance on opioids are by and large ineffective. So at the Birmingham VA, we took a very practical and simplistic approach to this very complex problem by bringing together two evidence-based practices. One, whole health clinical care in the setting of a shared medical appointment. And I'm going to tell you some of those results in just a moment. So how does a shared medical appointment work? We bring patients in together that have a common problem, and in this case, chronic pain and opioid reliance. We had 3 groups of approximately 30 patients each, and during the 9-week session, we introduced them to extensive opioid safety education, as well as whole health clinical model of care. And we tracked these results over a period of time. And what we noticed was that indeed opioid reliance decreased in a very linear fashion, with 45% making substantial decreases at 1 year and up to 70% at 2 years. So we have spread this practice to 13 other medical centers, including practice within our VISN and outside the VISN. We train these people in a 3-day mini residency program. So what we need to spread this practice is highly effective and functioning PAC groups in which to train. And we're looking for medical centers to partner with us and invite us to come and train your people there. Thank you.
Hello, Mike. How you doing? Thank you.
Thank you.
For the presentation. One of the questions I have is, in terms of sustainment, could you describe what a long-term sustainment plan would look like for this practice?
Well, the sustainment, our model is what we've done. So we do the 10-week session, and then we go to monthly maintenance groups for a whole year, and then we go to quarterly after that. Now, in terms of scale and spread, we've been able to spread this practice to, as I said, multiple other centers. Sustaining has been more challenging for those groups, and that's where some of the work that we're doing right now is to try to address their challenges through SWOT analysis to figure out, what do they have, what do they need to implement this further. And some of the things that I've put into a longer-term budget would be a project manager that would help keep these practices sustained.
So with that being said, I would assume that the project manager would be one of the key success factors for this practice. Would you care to talk about any more key success factors that you would need to move this practice forward?
Sure. I think very, very functioning teams, because, for example, I think our team in Birmingham owes a lot of its success to my business partner, Ms. Sherry Cox, who's in the audience, who's also a retired military colonel, so working together, and she's a health promotion disease prevention coordinator. So she has been very instrumental in working with these other teams and in gathering data from them.
Thank you. Mm-hmm. Well, I think I have one more question for you.
Sure.
In regards to the program, can you elaborate on some of the feedback that you've been receiving from the program?
Sure. The veterans are very, by and large, happy with what we're doing. We've actually showcased a couple of veterans that have been able to either come off or make substantial reductions in their opioids, and they've done some interviews with us through the Veterans Experience program. And then recently, we're working on a video for promotion. So.
All right. Thank you.
Good.
Still learning our time. We got 30 seconds left? I think we got. It
was 30 seconds.
Okay. So we're at stopping time? Okay. Thank you.
Yeah,
still learning our signs here.
All right, thank you.
Let me come. Thank you, Michael. I would now like to invite Tammy Splitstoser from the William S. Middleton Memorial Veterans Hospital. Thank you. Please welcome her.
Sharks, do your environmental management departments struggle to keep pace with high turnover rates and associated challenges? We found housekeepers with varying degrees of knowledge and competency training new hires insufficient to provide baseline expectations or optimize infection prevention practices. Our trainer serves as a preceptor during new employee orientation and spends a subsequent 9 days alongside them, emphasizing our roles in infection prevention, established best practices in hospital hygiene, providing on-the-job coaching of day-to-day tasks, all while embedding elements of whole health. Frontline employees indicated concerns regarding employee development, competency, and communication of expectations. Poor quality, insufficient, and lack of training were chronic complaints. Post-implementation data demonstrates sustained improvement in all three categories. Now, those complaints are rare. Across the same time frame, SHEP scores reflect an upward tick of patient satisfaction levels regarding the cleanliness of the Madison VA, with current ratings in the 90th percentile for every area of the hospital. Let's talk cost and resources. We offer an approved and rated GS9 PD. You provide one highly motivated training instructor, office space with a wall-mounted monitor, and preferably a dedicated housekeeping cart. Sharks, if you have high EMS turnover, are looking for a cost-effective way to improve employee development, mainstream EMS best practices, and improve your impact on facility infection prevention practices, I invite you to add a dedicated trainer to your EMS staff.
All right, Tammy. Am I on? There we go. Tammy, thank you very much for an excellent presentation. So you talked about the dedicated staff person. Can you elaborate on any additional resource inputs or costs associated with implementing this practice?
That was really it. The Madison VA, we did send our dedicated trainer to the AHE, Association for the Healthcare Environment, T-Chest training. We caught a little flack for that because that was technically a certification, which VA does not pay for. But I would not say that that training, while it was very, very useful, it is not mandatory. Really what's mandatory is someone who can take charge of a learning curriculum and stand it up.
Great. So in addition to those qualities of your chosen individual, could you talk to the group here about what some of the other keys to success would be in implementing this practice?
So a very unique aspect of our program is that our trainer has completed the whole health coaching program. And what we found about that was we have a hiring mandate that says we will hire combat veterans and or service-connected veterans first and foremost. That means a lot of times they're coming to us in a very transitional point in their lives. And they're really, really looking for that veteran-centric work experience. And being a whole health coach gives both the coach the ability to handle sometimes what comes up during that 9 days of training, but it also reassures that veteran that we are a veteran-supported employer.
Yeah, I really like that about this practice. In addition to doing good things for the quality of the EMS work, you're really doing a great job of supporting the employees, which I think helps to bolster the culture in the organization. So that's fantastic. So you, in your presentation, you cited SHEP data regarding the cleanliness of the hospital, which is great. So in terms of qualitative, what sort of feedback are you getting from the employees about this practice?
They want to expand it. So we have a on-site laundry facility, and basically our laundry facility wants to know when they get their version of me. So people, not just our own internal employees, but really the hospital has taken note.
That's great. Thank you.
Thank you, Tammy. Now I'd like to introduce you to Rebecca Hayden from the VA Central Iowa Healthcare System.
So if you are a veteran with Parkinson's disease, struggling to walk safely because of shuffling, freezing, and almost falling, wouldn't you want a Parkinson's Falls boot camp that would allow you to walk more safely, confidently, and not fall? If your program or your facility has not yet found a solution to the problem of falls, then this is the program for you. Your return on investment can be substantial. According to the CDC, an average cost for hospital stay for a fall injury is over $30,000, and 2/3 of our veterans with Parkinson's disease are recurrent fallers, so this can really add up. Our program meets 1 hour a week for 8 weeks. It's an outpatient program, and 4 veterans rotate between 4 different stations to work on rhythmic auditory stimulation or walking to a metronome beat, which encourages safe walking. They work on balance through the use of WE, a balance obstacle course, and doing Tai Chi. They work on power and amplitude through boxing, and we work on multitasking, which we find is improving both cognition and safe walking. All you need is a physical therapist, 2 physical therapy assistants, an occupational therapist, and a music therapist if you have one. All of their time is billable. Most of the equipment is available in therapy gyms. Dedicated space is required. Total cost to you, $7 for a metronome. You can't argue with our outcomes. 26 veterans have gone through our Falls Boot Camp so far, and on the mini-best test, one of the best outcome measures for Parkinson's, they've come out of the recurrent fall risk zone, are no longer at risk for falls, and on the 10-meter walk test, they've improved their walking speed so much they're no longer at risk for falls, and they maintain both of those gains over a 12-week follow-up. This cost-effective, evidence-based program with excellent outcomes and impact is so much fun that we always have a wait list for our Parkinson's Falls Boot Camp. We welcome your bids.
Thank you, Rebecca. Excellent presentation. I'm a big fan of this one and the things that you're doing specifically when it comes to using the Wii video games and the obstacle course itself. But the question I do have is, can you talk more about the resource inputs and costs that it took for you to implement it at your facility?
Okay, so really all that you need is dedicated space. We use our CLC, or Community Living Center dining room. You need about a 15-meter walk distance. That could be a hallway someplace if there's not a lot of traffic going through that hallway. But our Community Living Center is not used by rec therapy or to dine in from 10 to 11 every Thursday. Okay, so that's our dedicated time to be in that space. That 15-meter distance is needed for rhythmic auditory stimulation, which is the walking to the metronome beat, but our music therapist, Matt Lloyd, who's in the audience, plays music, their favorite style of music, on the guitar and strums that beat along with the metronome that I have going as I'm walking alongside them to keep them safe. So that's what's really needed space-wise. Then we have, a station set up for Tai Chi. That could be a quiet room. Sometimes it's out on the deck if the weather's nice. A little corner for the Wii, and another little space for like a boxing station or a multitasking station.
Nice, thank you.
And I can show those pictures again if that would be helpful. That might give a better idea. So it's really just our dining room in the CLC space-wise. Staff, we have all of the staff. It's just appropriating them for that hour. So freeing them up in their schedule to get there for that hour. All of their time is billable. No productivity is lost at all.
That's awesome.
And most of the equipment's in our therapy gym, so
Good deal.
yeah.
Such a dynamic practice. Can you talk about why this practice was so important to you personally?
Okay. Okay, well, I live in an area where Parkinson's disease is on the rise. In the Midwest, probably because of our use of herbicide and pesticide, but also because our Vietnam veterans are aging and Parkinson's disease is being diagnosed and just exponentially increasing from what I see, at least in my area. I am the physical therapist who is, tasked with trying to prevent falls. And so my job is to make sure they don't fall. And if they do fall, not to have a repeat fall. So I looked at the literature and looked at best practices, and we're lucky enough to have a music therapist who we sent off to also be NMT trained. And so he knows how to use the rhythmic auditory stimulation protocol to the T. That would be an important component. That person doesn't have to be a music therapist, but we do recommend that training. It's about $600, a couple 2-3 day training. And so it really pays off for doing that more accurately.
Thank you.
Yes.
Thank you, Rebecca. Next up, I'd like to invite Jill Huded to the VA from the VA Northeast Ohio Healthcare System. Rebecca, we may have to see if, can we recover our clicker from you?
You can click for me.
You just wanted to walk around the room.
Okay, thank you.
Yeah.
Okay, I'm really excited to be here. I'm an acute care geriatrician from the Cleveland VA, and I'm here today to talk to you about older veterans. So there's over 1 million annual ED encounters for veterans 65 years and older within VA alone. And compared to our non-VA emergency departments, where maybe 18% of all their encounters are with 65 years and older, VA is seeing 40% of all of our ED encounters being the older of the old. And I'm sure that in the audience, no one is like itching to send your older parent or grandparent or neighbor to the emergency room. You know that this is often not a great experience, and it's really hard to meet the needs of our older patients in the emergency setting. So these struggles were recognized with geriatric ED guidelines, followed by a geriatric ED accreditation program through ACEP in the last 5 years. So enter GeriVet. GeriVet was established in 2016 at the Cleveland VA and works to hotspot the most frail older veterans as they enter ED triage. It provides a multi-component educational curriculum for ED staff to perform geriatric screens and care coordination. And then very importantly, it initiates VA home and community resources for our older veterans at the time of their ED encounter, really working to help keep these older veterans healthy and happy at home. And this has all set the stage for Cleveland to become the first VA to be geriatric ED accredited in the nation. And we've had a lot of fun working with various sites and geriatric ED programming throughout the country. You do need a medical director that has time to champion this work, and also GeriVet liaisons. So these are going to be your ED nurses, an ICT, an LPN, somebody that can work with patients while they are there in the ED and perform that care coordination and that continuity of care. And then through GeriVet, you will have access to IT tools, CPRS, the training curriculum, everything that you might need to set the stage for geriatric ED accreditation. So thank you.
Okay, thank you very much for an excellent presentation, Dr. Huded.
Yes.
So we talked a little bit about resources, and you had mentioned in terms of data, over 1,000 at-risk veterans. You're in, I believe you said 14 different VA medical centers, so you have a lot of implementation experience there. That's all fantastic.
We've worked with 14
Worked with
in
14.
various capacities.
Thank you for the
Yes.
clarification on that. So in terms of working with 14 different centers, having implemented a number of those, what sort of feedback are you getting from clinicians on implementing GeriVet?
Right. So this program can be as expansive as you want it to be. We know that geriatric syndromes aren't few in number necessarily, so we've really encouraged each site to work with their medical center leadership to decide what the priorities are for them. Is it detecting delirium? Is it providing DME at the time of their ED visit? Is it connecting with social work? So I think that has been key, and really starting at a very focused level and then expanding from there.
Sure. And am I understanding correctly that you have essentially an orientation or a number of educational resources to help facilities implement this stuff? So you basically just need the FTE resources at the implementing facility, and all the information and knowledge is there for them already?
Correct. So we've actually hosted 3 1 to 2 day GeriVet boot camps already in conjunction with our Cleveland GREC. And we have a SharePoint, we've got training videos, and we've worked closely with the American College of Emergency Physicians to make sure that our curriculum aligns with what's being promoted across the country.
Great. To piggyback on something that you had said just a moment ago, looking at a long-term sustainment plan for GeriVet at a facility, what would that look like?
So it comes down to a lot of support from your ED medical and nursing directors, because this is multidisciplinary. We need physician buy-in, nursing buy-in, health tech buy-in, the whole gamut. And ensuring that we have protected time for geriatric ED education is going to be key.
Great. We have about 20 seconds left. Any additional information you'd like to share about your practice for the Sharks?
We're just really excited. I mean, there's a lot of excitement throughout VA in this work, from the national level and down within emergency medicine and geriatric. So please reach out to me if you have any questions.
Nice job.
Thank
Thanks so
you.
much.
Thank you, Jill, and thank you for leaving the clicker here. I would like to introduce Rebecca Schluter from Lexington VA Medical Center. Come on up, Rebecca. Woo. Yes.
What is the most expensive item in the purchase care budget? What cost the VA $647 million in fiscal year 19 alone? Dialysis. The low-cost solution to this concern is Healthier Kidneys Through Your Kitchen. This whole health nutrition program helps veterans with early kidney disease reduce their need for dialysis at a value price point. Chronic kidney disease, or CKD, is the 4th most frequent diagnosis among VA users. 13,000 veterans each year develop kidney failure requiring dialysis. A major concern is that veterans with CKD are often unaware that they even have it. Lexington started Healthier Kidneys Through Your Kitchen in 2017. Due to its success, it spread to 8 VAs in 2 years. During class, the dietitian discusses medical nutrition therapy for kidney disease and the benefits of increasing activity. There's a healthy teaching kitchen demonstration and activity break where veterans receive a pedometer and resistance bands. Veterans taste the recipe and take a copy home along with other resources. Nutrition intervention can prevent kidney failure. Prior to our program start, a Lexington PAC showed only 37% of veterans with CKD had met with a dietitian. With this program, that percentage rose to 65%. Over 300 veterans have participated so far, and they are so grateful that they did. At least 30 nutrition departments have expressed interest in bringing this whole health program to their facility. We now have a non-cooking version of the program, expanding telehealth options. Our program is FTE neutral and low cost. Our ask is bidding $3,000 to $5,000 per year to support purchasing resources for participating veterans. Costs may decrease as we develop internal resources. An optimal experience would be funding a dietitian to visit an existing site for hands-on learning. This program helps your facility's bottom line, and more importantly, improves the quality of life for our much-deserving veterans.
Thank you. A lot of information, a lot of great information. I appreciate the presentation. Very, very well done. One of the things that you said, and I believe, correct me if I'm wrong, you said it was in 8 VA facilities within the last 2 years? Perfect, perfect. One of the questions I do have for you, though, is what are you doing in terms of collecting the data, and how can you talk about how that's been an impact
Sure. So at each class, we measure veterans' weights and waist circumferences, and then we also assess their renal-specific labs. After the one class, we encourage an individual appointment with a registered dietitian where they meet one-on-one for medical nutrition therapy and behavior change counseling to go over their specific renal labs. We've had interest from a variety of people wanting to look at this population, including Dr. Kalantar, at the nephrologist in California, who is the chief editor for the Journal of Renal Nutrition, because with all this data, we haven't done a whole bunch with it just yet. We expect to see positive outcomes with renal disease. You're not going to reverse the damage, but we're hoping to slow it. So it's kind of measuring prevention. But we've seen, just anecdotally, veterans improve blood pressure. Some have joined MOVE and lost 40 pounds. They've got off their blood pressure or reduced diabetes medication. So that's just data just from specific individuals.
Perfect, thank you. So you talked about, having a teaching kitchen and some of the other resources that you needed to sustain it and also expand it and scale it. Can you actually talk about that some more in regards to
Sure.
the resources?
Most VAs have healthy teaching kitchens through their nutrition departments. So, if you feed them, they will come. So all veterans enjoy that part. Their caregivers are encouraged to attend as well. So they like the fact that they get recipes. They get to taste something different than they normally would prepare at home. The healthy teaching kitchen is a key component of it. But because we want to expand into telehealth, we do have a non-cooking version. If anyone develops, virtual tasting and smelling capacity, come talk to us. But we don't have that at this point. One thing I did want to say too, earlier at a presentation, they said, think about if what you're doing in 2019 is going to impact 2030. This program is going to impact 2030. In Lexington, we spent $2 million on dialysis last year alone. If we don't do anything, that number is only going to continue to rise. Veterans are so grateful for this program because they at least now have the opportunity to modify their lifestyle to prevent or delay ever having to go on dialysis. So.
Thank you.
All right. Thank you, Rebecca. Nice 3-box plug. Could we have Jeffrey Kinderdietz also from VA Central Iowa Healthcare System? Thank you, sir.
All right. Good afternoon, everybody. I was seeing if I would get a shout back here. All right, so what we're going to be talking about is one consult pathway. And so the simplest question that I have for you is the directors and the Sharks and people involved in innovation, do you want an easy button, an easy way to reduce opioid use and reduce risk for veterans? If you do, then one consult pathway is the way to do it. Mr. Dunning, our esteemed Mr. Dunning, was up here earlier with his fantastic shark socks and was talking about siloed service lines, right? We have siloed service lines which are problematic in the VA system. They're problematic for all of these reasons. Unnecessary consult prerequisites that get built over time, poor communication that happens between them, incomplete knowledge of offering for whole health and complementary and integrative health services, multiple consults trying to get veterans the help that they want, more discontinued consults as a result of that, increased delays in care and frustration amongst our veterans. And all of this leads to a decrease in consults for our pain clinics. So one consult pathway is the easy button solution to that. It reduces the number of unnecessary consults, connects veterans with the beneficial help that they desired the first time around, and allows access for whole health and pain services. So 80% of our primary care providers were dissatisfied with our process prior to one consult. After one consult, 80% were extremely satisfied and said the process was very easy. Our consults doubled as a result of one consult, and that has been sustained over a 6-month period of time, more than doubled. Primary care providers like the process, and as a result, they're getting more people to us for care. So what we have seen is an OSI reduction in our metrics across the board, opioid reductions across the board, And in risk categories like benzo-opioid combos, you see a reduction there of 62%. The last thing I'll mention is that we also saw a reduction in our proportion of congressional inquiries per consult. Initially, prior to one consult, that was 0.02, post one consult, 0.008, and that has been sustained over 6 months as well. So if you would like, again, to increase access to pain services, reduce risk, reduce opioid use for veterans, then bid for one consult.
Nice job. Thank you for the presentation. So can you talk to us a little more about resource inputs and costs associated with implementing this practice?
So the biggest resource that your team is going to need is to get people together in a room and listen. So what we did was we started basically a listening tour in a sense. We went to our primary care providers and we listened. Talked to them about being overburdened, what it was that we could do to improve that process for them. Then got people from the pain team together in a room and listened to them. Got people from mental health together in a room and listened to them. And then when we put together the solution, which was the one consult pathway, we got everybody back together in a room and we started talking about solutions and how we could implement this solution and how we could put it together. Now, the great news is we've already created the wheel. So we don't need to do that again. We just need to implement the wheel at your facility. So we've started actually implementation in our visit at 3 different sites that have already just through word of mouth said, we want this process and we want to implement it. So we've started that process. We would love for this process to expand because we've seen the benefits for our veterans, the reduction in frustration. We've seen the primary care providers loving this process, the improvement in communication between primary care and mental health and the pain clinics. And we're providing more people with help, and we're reducing risk.
Great. So you had a lot of information in your presentation with regard to the efficacy of your practice, which was great. Reduction in benzo opioids by 62%. Fantastic. I also like the way that you illustrated a reduction in congressionals per consult. I thought that was a great way to illustrate value there. What about the feedback that you're receiving both from clinicians who have implemented as well as the veterans who are being served by this consult?
So both love it. One of the things that we saw as problematic initially was there's a lot of information with the implementation of whole health, with the implementation of complementary integrative health services. Put yourself in the shoes of a primary care provider who in a very short period of time wants to help a veteran sitting across from them, but may not have all of the information at the disposal of experts in the pain clinic or pain land that I call it. And we want to make sure as part of this process, as part of this pathway, that we're affording them the opportunity to have easy access to that information so that they can provide it for every veteran. But if they don't have the time to be able to do that, they get them on the pathway over to us and we can provide that information for them, again, to ensure that the veteran's getting the help that they want the first time around and that we're not frustrating them in the system.
That's great. Thank you very much.
Thank you, Jeffrey. I'd now like to invite Daniel Hall from VA Pittsburgh Healthcare System to the stage.
Thank you. Here's the problem. There is no such thing as low-risk surgery in frail patients. 1 in 3 frail veterans will die within 6 months of their surgery. So even minor surgery is risky. And until now, there's been no way to identify frail patients in real time at the point of care when they make decisions with their surgeons. So here's the solution. We developed and thoroughly validated the Risk Analysis Index. It is a rapid point-of-care survey that measures frailty. It requires only 12 questions that can be answered by either the patient or the surgeon or another clinician, and focuses on things like functional performance, activities of daily living, shortness of breath, or appetite. And using this online calculator, we've now measured it more than 350,000 times across 5 hospitals to accurately identify the 5 to 10% of patients at greatest risk for poor outcomes. Now, If you're frail, the next step is prehabilitation. For example, preoperative interdisciplinary review of the care plan at the Omaha VA cut mortality from 25 to 8%. That is a threefold survival advantage after controlling for age and multimorbidity. Another option would be preoperative palliative care consultation to clarify the goals. And in Pittsburgh, we changed the care plan in 1 out of 5 patients. 21% of them chose non-operative management. And those that did go on to have surgery, if you do preoperative exercise training, you can improve their functional performance in as little as 3 weeks. So all we need from you is to identify a few clinical champions to lead the intervention team. We can then customize our intervention to leverage your existing resources. That's all that it takes. And interventions like these have cut case costs for surgery by 20% while adding 1/2 quality adjusted life year per each person screened. So what are you waiting for? We're ready to help you transform the clinical care of frail veterans at your VA. Thank you, and I welcome your bids and questions.
Thank you, Dr. Hall. Two-pronged question. Could you describe how the practice, can you describe the practice from a veteran's perspective and how they're impacted, and then can you describe it from a clinician's perspective?
Okay, let's start with the clinician's perspective, because this is really a bit more of a clinician-facing intervention. My problem is that I'm supposed to be super efficient in my clinic. And I've got a hammer, I like to hit nails, I'm really good at that technical expertise, but sometimes that nail might be a little bit bent or a little bit rusty. I need a tool that's invisible to the patient that says, hop, stop the line, pay close attention to this one. Be super efficient with all of the robust patients. But with the high-risk ones, you want to step back, you want to pause, you want to think a little bit more, you want to provide additional resources to that limited number of folks. From the patient's perspective, nobody wants to be labeled as frail, right? So what we want to be able to do is identify that risk in a way that allows me as the clinician to come up to that very gently on the side and sort of say, look, I really wish and hope that we could solve this problem, but I'm afraid that there's not an easy, quick solution to the problem. Let's get into the details so that we make sure that the care that we give you is consistent with your values.
Thank you. And can you talk about how you plan to scale and sustain the practice beyond what you're doing in Pittsburgh?
Scaling is really easy. It takes 30 seconds of additional clinic time. It does not disrupt flow. We've implemented it in a lot of different areas to get the first piece of information, which is to identify which of these patients are at high risk. Then after that, you need to work with the passion of the resources that you have, whether you've got a palliative care specialist who wants to do preoperative counseling, that's a different ball of wax, and we've developed some curricular tools to help with that, or to put an interdisciplinary preoperative team together for the evaluation of these patients. These FTE are already in existence. You just need to continue to support 10 to 20% of a few leaders to be able to pull that human capital around these most vulnerable patients.
Great, we have 30 seconds. Is there anything else that you would like to add?
I think that this is one area that it is not coincidental that the VA has led the nation. We do not, in the VA context, have the kind of perverse incentives that encourage me and my colleagues in the private sector to do things that may not necessarily help the patients. We can again be at the leadership in the same way that we were with the VA SQIP. We can be the leader of the nation to show folks how to deal with the silver tsunami that is coming our way.
Thank you.
Thank you.
Thanks, Daniel. Thanks so much, Daniel. So we're going to go ahead and take a short break while we get the rest of our finalists prepared. So please be back in the ballroom in 10 minutes. Don't forget to download the app and be ready to vote. Thank you.
That's a new one. That's right. That's a new one. Thank you.
Thank you, sir. Okay, everybody, we're going to kick off the second half of our Shark Tank program. If we could get those back doors closed, back there on the back left. Welcome back, everybody. I'd like to introduce you to James Henry from VA Portland Healthcare System. Please give him a warm round of applause. Yes, sir.
Hello, Sharks and everyone. I've been at the VA for 32 years, and I've focused mostly on helping veterans who have ringing in their ears. Tinnitus, which has no cure, is the most prevalent service-connected disability. And 13% of all VA patients, that's 1.2 million veterans, seek help from VA clinicians for their tinnitus. Imagine trying to read, concentrate, or sleep with nonstop tinnitus. Then imagine having PTSD, TBI, or chronic pain along with tinnitus. One veteran said, "That noise is my whole life. It affects everything. It's the most debilitating thing I've ever come across." We've developed an efficient step care method called progressive tinnitus management, which has been endorsed by VA Central Office and which has improved the lives of many veterans. One veteran said, "PTM has allowed me to endure a fuller life without limitations. It has made me a whole person again." Unfortunately, most veterans don't have access to this program because implementation across the VA has been a real problem. So to create access, we've developed a centralized telehealth version of PTM called tele-PTM. Now, your bid would support each audiologist at your site receiving 1 hour of protected time to complete our TMS training. They would learn how to use this questionnaire, which takes about 5 minutes with patients, and they would learn how to refer their veterans as needed to our tele-PTM experts in Portland. And we would take over with those patients when you do that. So this program would fill a critical healthcare gap by ensuring that every veteran has access to evidence-based clinical services for tinnitus. So I'm here today to ask you to support this program, which is vital for our veterans. Thank you very much.
Thank you for the presentation. As a combat veteran who has a little bit of that thing, I want to tell you that I very much appreciate that you've implemented this practice. So I see that you have the survey up here. Can you talk to me a little bit about how you're using data to illustrate the impact of this practice?
Well, this survey is really a clinical tool. This is really not an outcome instrument. It could be an outcome instrument, but it's really short and sweet. The idea behind this survey is to separate out hearing issues from tinnitus issues, which often get confused by patients. So this is really the key to an audiologist knowing what to do with that patient. So an audiologist is like the gatekeeper to the whole program. They need to go to audiology first because they probably have hearing loss. They need to get their hearing tested. They might need hearing aids. They need to know if their tinnitus is a problem, and if it is, then they may need further services, and that's where we would step in with our telehealth program if those services weren't available at the local VA.
So how many veterans have been through the tele-PTM program?
Well, I would say we'd have to say thousands. We've done a randomized controlled trial with PTM, multi-site, and we've done a randomized controlled trial with tele-PTM. And just between those two trials, there were over 500 research participants.
Wow. So, and does the data show any difference in terms of a comparison between PTM and tele-PTM effectiveness?
We didn't compare those two. We did PTM compared to waitlist control, and PTM was clearly more effective. And we did tele-PTM compared to waitlist control. And that was a national program. We did tele-PTM nationwide with over 200 research participants. And it was very effective.
Fantastic. So let's talk about, after the quantitative, let's talk about qualitative. What are you hearing from veterans in terms of feedback?
For the most part, they really appreciate it. It's a self-efficacy program. I mean, once they get through audiology, they move on to multidisciplinary. We need mental health and audiologists involved in that next level of care. And if they do get that level of care, they're generally very pleased with it, and they feel like they literally do get their life back.
That's great. 30 seconds left. Any last thoughts or anything you'd like the audience and the Sharks to know about your practice?
I would just say we've been working with these veterans for 25 years. We've done multiple research projects. We're passionate about this program. We're passionate about helping veterans. And we realize that tinnitus care across the VA is non-standardized. It really does need to become standardized and needs to be evidence-based, and that's what we can offer.
Thanks very much.
Thank you.
Thank you, James. I just wanted to add in that we've had about 1,500 chime in through or tune in through virtual viewing, so we've got a really great online audience as well. Now we're going to invite up Jeanette Salvaggio from VA Northeast Ohio Healthcare System.
Hello, everyone. I have a question for the audience. If a veteran in crisis were to call you on the phone right now, would you know what to do? Would you know who to contact? And I see hands of people that do know. So we have 1, 2, 3, 4. So we have more than what I thought. We have 6 or 7. So we're in a room of about, I'd say 300 would be a fair number. Well, my story begins with I had contacted a patient returning her call regarding her medications. I'm a pharmacy technician. I was just telling her that we were going to overnight some medications to her. When she answered the phone, she was crying and she was contemplating suicide. I didn't know what to do. How do I get her help when I have a patient in crisis on the phone? The pharmacist next to me had a patient, and everyone else in the pharmacy was too far away for me to call for help. I kept talking to the patient until the pharmacist was finished. The pharmacist was aware of what was going on. She called for help. Mental health came down and took over the call. With that, I knew I had to make this process better. I made the suicide alert card. What it is just a laminated card. It's a brightly colored so you can wave it and catches attention. And on the back is all our contact information for our mental health team. I pitched the idea to my supervisor. He said yes. We posted them at the phones. That afternoon we posted them. Another technician gets a call from a veteran. She takes it off the wall, hands it to the supervisor, calls mental health. They responded in less than 1 minute. The card is modifiable. It's user-friendly. It's a wonderful tool for frontline employees. It's cost-effective. And it saves lives. When a patient that is in crisis calls us, their fate is in our hands. So we need to get them help quickly. Okay. Thank you. All right.
Thank you, Jeanette.
Thank you.
Question I have for you is in regards to the reduced response time that you mentioned with the cards that you created. Can you elaborate more on that? Was there any baselines that you wanted to identify to try to reduce the times? Can you speak on that?
So actually what happened is when the card was used for the first time, my supervisor had called the mental health team. I asked him, how was it? And he said it was easy. There was no thought required. So there wasn't any scrambling around of who's working, mental health today, what are the numbers, especially we have had our extensions changed. So we called them and they were down in less than a minute. So they come in our facility, our procedure is they come down, they take over the call.
And I appreciate you providing the personal story that you did to first start the presentation, how it affected you personally. Can you talk about what other key elements were associated with the success of this practice at your facility?
Yes. So the first one that we used the card for, that particular patient who had called, we actually had to call 911 and he had to be taken to the hospital. That was 3.5 years ago, and I actually saw that patient in our clinic 2 weeks ago.
Okay, great. Can you talk about the impact that it had on the participants from a veteran perspective as well as a employee perspective?
It actually, I forgot to change my slides. Actually, it is impacted a lot, mainly for employees because, we have the tool to use. So, it benefits the patients the most, because we're saving lives, but also it's a tool for us because we have it right there. It's posted at every phone, and the second photo you can see, we have it posted at every phone.
Great. Is there any other additional information that you would like to add?
Yes, actually, every medical facility has everything in place to do this. They do not need any more EFTs. They have graphic artists. They have the tools to do this. They just need to implement it.
Okay. And last question that I have, in terms of sustainment, have you thought about sustainment and what that looks like as far as you expanding the practice beyond your facility?
Yes, this should be implemented at every phone in the VA. With what our veterans go through, suicide isn't going to go away, and we need to help them the best we can, and this is a start to suicide prevention,
So
to save them.
Have you've saved lives with this practice?
Yes, we had to call 911, and yes.
Just making sure we make that point.
Yes, actually, yes. The card facilitates in getting the veterans the help that they need.
Okay.
Thank
All
you.
right. Thank you, Jeanette. Next up, I'd like to introduce Lisa Heck from Central Texas Veterans Healthcare System. Here you go, Lisa.
All right, good afternoon. My name is Lisa Heck, and I'm the Facility Telehealth Coordinator at Central Texas Veterans Healthcare System. What if I told you you could implement a program that would increase access to care with minimal cost and improve quality? Isn't this something every facility seeks to achieve? Well, we've done just that. Our Store and Forward Teledentistry program was created because our previous process required our dental provider to visit our community living center and complete the screenings in person. This process was inefficient and resulted in both loss of productivity and access. Our current process only requires 2 dental assistants to visit the community living center, capture the images, and upload them into the medical record. The provider is then able to review the images and complete the treatment plan at a later date and time. The dental provider remains in the dental clinic, so this increases appointment slots for our veterans. Our practice saw a decrease in clinic operational costs from $120 per hour when the provider was visiting the community center in person to now only $44 per hour with the dental assistants going over and completing the images. We also saw that our provider had an increase in number of visits completed by 71%, and the provider's productivity increased an additional 73%. Our process has minimal startup cost. Most of the equipment is readily available in the dental clinic. We do require the use of a point-and-shoot digital camera. These can be purchased for a few $100s, and then also access to either a computer on wheels or a laptop. We do have to have the help of some staff that are already on site to get this implemented, and our practice is ideal to be implemented at other facilities with a community living center and who do not want to move either the patient or the provider to and from the dental clinic. So Sharks, who's ready to implement our program?
Great job, great presentation, thank you. So for context, how far is your CLC from your dental clinic?
So our facility is actually across the campus.
But it's on the same campus?
It's on the same campus, but it is across the facility. Now, we do have another CLC as well at a different facility in a different town.
Okay, got it, thank you. So you did a great job of talking about the resources in your ask, so I won't ask any questions about that. One question I do have for you, though, is what do you feel are the key elements to success in implementing this practice?
Right, so I think one of the big things about our practice is we really have to think about the patients that we're screening. This is a required screening for every patient admitted to the community living center. It has to be done within 14 days. These patients that are being admitted are patients who are being admitted for hospice care. These are medically fragile patients. These are patients who have mobility issues. So there's two options. Either you're transporting the patients to the dental clinic or you're sending the dentist to that. Either way, we're using resources that could be better allocated to another task, or we're decreasing the physician's time.
Good question. Or I should say good answer. I'm asking the questions. They're great questions, too. Don't count that against our time. Okay, so my other question was feedback from employees and veterans. What kind of feedback are you getting?
So from our dental provider, he has been very happy. This process has allowed him to open up an additional entire afternoon where he's actually able now to provide care in the dental clinic. The veterans, what we've heard is we're taking the care to them. So we're going to them and we're meeting them where they're at to make sure they're getting this care.
Excellent. So final thoughts. Any last things that you want to communicate to our audience and to the Sharks?
So I just think that there is additional opportunities to take this practice. We are looking at how do we send this to the C-Box and do the same type of thing in our C-Box, especially with Mission Act. We're trying to figure out how do we keep these patients in. This is something we can look at replicating in our C-Box as well.
Very good. Thank you very much.
All right, thank you.
Thank you, Lisa. Next up, we have Jessica Holly from Minneapolis VA Healthcare System.
Good afternoon. I'd like you to meet Mrs. Cole, a veteran who needs a power wheelchair, living in a contract nursing home in a rural area 3 hours away from the VA. She needs a seating assessment, but her pressure ulcers make travel really difficult, and it's forecasted to snow a lot. So how can we ensure this veteran gets what she needs? Tele-rehab is the solution. Our wheeled mobility clinic provides technology and expertise to provide patient-centered care via video. The process begins when nursing homes alert us to a veteran's mobility needs. We respond with an outreach call to provide education about what telehealth is, and we complete a test visit. Next, VA therapists and nursing home staff schedule an appointment and complete a comprehensive interactive assessment in the patient's own environment. VA then orders and delivers a custom chair, after which additional telehealth visits are completed to ensure proper fit and education. As you can see, this clinic has so many benefits. In this case example, our VA therapists work closely with the veteran, her caregiver, nursing home staff, and a community wheelchair vendor over the course of 4 different telehealth visits to meet the veteran's needs in a safe and timely fashion. Mrs. Cole now has a custom power wheelchair that reduces her caregiver needs and increases her independence, and also prevents future medical complications associated with her MS. Tele-rehab saved this veteran hours of uncomfortable and unnecessary travel while honoring her preference to choose VA healthcare. The VA also saved more than $2,500 just in travel costs alone. A tele-rehab mobility clinic is an innovative practice and a win-win for all. To begin, you need skilled staff, basic technology, and community partners, which you already have. By building on these resources, you can better meet the needs of your community veterans. Tele-rehab is a smart concept that is simple to implement, and the impact is clear. We ask you to submit your bid today.
Hey, Jessica, good presentation, thank you. So, going back to your slide, you mentioned about the operational cost. I think you said roughly around $2,500, and it decreased to zero?
Correct.
All right, so you also mentioned in your write-up about the minimum overhead cost.
Right.
Is there an assumption that there is no cost, or is there some, and can you talk about that?
Yeah, I think that's a great question. How we designed our clinic is we really had everything we needed. We just basically combined our telehealth and our TRUI team with our contract nursing home program. We were able to recognize that these veterans are in a nursing home for a reason, travel's difficult, and the Minneapolis VA has over 60 contract nursing homes that we work with, and so travel is a big cost to bring them to our VA because we serve a lot of rural veterans. So I think The basic startup costs are really, you already have what you need, and it's just building on those resources.
And can you talk about what was defined as success at your facility with this practice?
Yeah, I think we've had so many successes with this clinic in the short year that we've been up and running, and it's, I think there's a lot more that we can do with it. The veterans have been very vocal about being satisfied by not having to get in that wheelchair van and driving, 3 to 4 hours to the VA. The nursing home staff are very, very pleased to work with our VA therapists who specialize in wheelchairs. They know what they're talking about. And so we offer an additional support to our community partners who are caring for our veterans every single day.
So you talked about the experience from the veteran perspective as well as the employer perspective. Can you talk about why it's so important for you that you're doing this practice?
Yeah, I think as I think the silver tsunami was a beautiful language that he used earlier, our veteran population is aging and our community partnerships are growing. And so how do we combine the VA healthcare system and the expertise that we have to care for our veterans in the settings that they're choosing to live in?
Perfect. And is there anything else that you would like to add or elaborate on for this practice?
Yeah, I just want to highlight that I think our community partnerships with the VA are so important. We're doing a lot of work in the private sector to really honor where the veterans want to choose care, but what we're really finding is that our veterans still want to be connected to us at the VA Healthcare Center and want to choose us as providers. And so how can we honor to bring our expertise and our healthcare to them without burdening them with the travel?
Perfect. Thank you very much.
Thank you, Jessica. Next up, also from Minneapolis VA Healthcare System, please welcome Christina McGovern.
Since veterans with spinal cord injuries and disorders must now have access to whole health care, it's an exciting time to consider the implementation of this system and culture change. But how do we engage our veterans in lifelong health, well-being, and resilience? At our SCID Center, we have developed a pathway to whole health implementation. The pathway begins with our veterans. Their complex medical challenges do not define them. Instead, we ask, what matters most to you? Through well-being programs and whole health-driven clinical care, we partner with our veterans as they engage their mission, aspiration, and purpose. Inspired by the Whole Health Circle of Health, as seen on the left of the screen, the circle to the right depicts our whole health SCID initiatives. Some are fully implemented, such as acupuncture, and others are being newly developed, such as virtual reality. As a high-reliability health system, our development strategy includes surveys to assess health outcomes and to guide the effective integration of whole health measures. For example, Hallie Boyd investigated the use of massage therapy as part of a symptom management plan and found massage greatly decreases our veterans' pain and anxiety. In a second study, Caitlin Erickson found that implementation of a mindfulness-based nutrition education program empowers our veterans with elevated food and awareness and increased personal health inventory ratings. Whole health implementation at an SCID hub or spoke site would utilize change management principles for system redesign. For example, key factors needed to achieve lasting change are awareness of and desire to support the change. These factors are grounded in the development of a whole health committee. Knowledge is provided through staff education, abilities are enhanced through self-care, classes and integrative therapy sessions such as massage, and reinforcement of the system change is facilitated with a part-time whole health program coordinator. Through whole health system redesign in our inpatient and outpatient units, we have partnered with our veterans to empower and equip them for lifelong health, well-being, and resilience. Thank you.
Nice presentation, thanks.
Thank you.
So my first question is about resources, and you did just speak to it, but I want to kind of clarify a little bit. So this is a whole health program specific to SCI, and my curiosity is when you talk about the resources that you need for this, are these additional resources above and beyond what other facilities may already have relative to whole health, or can you leverage those existing resources?
Yeah, so I think that it is definitely possible to leverage existing resources. I did mention that you would need, for example, a whole health coordinator or a massage therapist, so that would require FTE. But beyond that, a lot of the other factors of the implementation are already present in many facilities, yeah.
Great. So, and just for my awareness in my caveman brain, when you say whole health coordinator, 0.5 FTE as it is on the slide, that 0.5 FTE.
Or 0.3 for the
0.3,
coordinator.
sorry,
yeah.
my memory needs work as well. But is that specific for the SCI program?
It
You mean
is,
0.3
yes,
specifically
that's
for?
correct.
Okay, understood. Thank you. So what would a long-term sustainment plan look like at a facility?
So I think a long-term sustainment plan really gets back to really like the pro-SIAD card development of system change. So, you know, you need an awareness of the change, you need that desire for the change, and that really comes from having a whole health committee. I think, you know, you need to get, whole health is a multi-factored implementation, and you really need to have buy-in from everyone. So having that committee, that interdisciplinary committee to support the change is necessary. And then I think, again, you know, education is key. So you really need to have staff education as a foundation for the implementation of this practice.
Great. So what about feedback from veterans? What are you hearing from veterans who have gone through this programming?
So veterans love it. Especially with regard to pain management. You know, in SCI, we have a lot of chronic pain, and you know, medications can help somewhat, but unfortunately they don't always completely manage the pain for our veterans. And so for them, you know, especially having massage as something that's available to them, they're saying, you know, I don't need to take as much medication today because I had massage therapy, or my pain is reduced and I can do my rehabilitation today. So.
Great. Thank you very much.
Thank you.
Thank you, Christina. I love the whole health presence in this year's group of finalists. Next up, we'd like to invite Michael Brody from VA Central Office. Sir? Yeah!
Good afternoon, Sharks. My name is Mike Brody, and I am one of the inventors of Tour of Duty, also known as TOD. Tour of Duty is the first standardized VA-wide, professional-focused, and flexible training that includes using and learning military cultural competency to better connect with veterans more viscerally, using the oath, the federal oath, to celebrate civil service and excellence in the VA, and using whole health to better care for our VA employee professionals. So what does Tour of Duty do? First, TOD training focuses on giving a tool to leadership to help inspire and motivate employees to understand the link between serving the VA and civil service, the oath, and I care values, and the United States of America. It compels people to do the right thing all the time. After training VA professionals, employees who hear, "Thank you for your service," they will know that it does not just apply to Army and military veterans. They will know that it applies to both them, GS1s, through VA medical directors. The missing ingredient for VA employees that they tell us is to know publicly that they are valued and that their contributions count. TOD also explores the language of the military as a way of connecting quickly, smartly, and with confidence. We teach a method of connecting with not just the veteran, but those around the veteran, the brats, the Blue Star families, the Gold Star families. Are we done?
Yeah, can you take another 30 seconds and hit the highlights?
All right, and then, of
Sorry to
course,
rush you.
explains and discusses whole health to make our lives better as employees and human beings. TOD seeks to educate leaders and employees about the connection between health performance, work performance, and a work-life balance. That concludes my presentation.
Thank you, Mike.
Hey, how's it going?
Good, good. So a couple of questions in terms of implementation of
Sure.
the practice, right? So one of the things I want to know, and I think everyone would like to know, can you share with us more about the resource inputs and costs that it took to implement the practice, or where has it been implemented? Can you explain and
So
expand on that?
it's been a prototype. We've developed this over 11 years. I need to mention at this point in time, Joy Philly, Christian G. Mercurio, Cajun Kumau, and Frederick White, all of us helped to develop this over 11 years. We've implemented this at 12 locations, and part of what folks are saying is right there. VA professionals are saying this is the best training that they've had in or out of the military, and that's veterans included. They are saying, why isn't this standard training for every VA employee? Why wasn't I given the training when I came to the VA over 25 years ago? So we're looking at a population of folks that does not necessarily feel valued. It's not because their leaders are not doing a great job, it's because they're overwhelmed. And we need to give our VA employees an institutional hug.
Okay, so we talk about the qualitative perspective, and I appreciate you talking about that. Is there any additional data points and things that you're collecting to identify what the impact is of the practice?
Well, the type of training would be over, and this is in reference to your initial question, which is an 8-hour TOD facilitated experience. The delivery method is direct engagement by a team of folks coming to your facility or your visit. We believe that train-the-trainer is not necessarily a best practice in VA. It's a cost-effective method, but ultimately, at the end of the day, that messaging gets lost, depending upon who, in fact, is that facilitator. So we need one VA veteran, one person that works for the VA that happens to be a military veteran, and then that other team member has to be a civil servant and an employee. That team member, those two team members give the right picture, the right shot group for our folks in the audience who are looking to receive the right message.
Okay, I think our time is up. Thank you.
Thank you.
Thank you, Michael. Next up, I'd like to introduce Shannon Teague from VA Long Beach Healthcare System. Let's see. Thank you, sir. You're not the first one to do that. It's quite all right.
With 17 veterans a day dying by suicide, we can all agree that one veteran a day is too many. Despite VA strides to reduce that, something's been missing. We're dispatched with local law enforcement to go on calls for service for at-risk veterans. We paired a VA police officer and a VA clinician to go on calls for crisis, welfare checks, and follow-up care. We partner with suicide prevention, urgent mental health clinic, and specialty care clinics to reach those vets who have stopped showing up for mental health appointments, as well as those uniques who have not stepped foot on VA ground. As you can see pictured here, this is one of the calls for service we went on where a veteran was in crisis and climbed on top of the Vincent St. Thomas Bridge in Long Beach. Through VMET, we were able to de-escalate, re-engage, and bring that veteran home for the unique treatment that he so greatly deserved. Prior to VMET, he was not connected to the VA and likely could have ended up in jail or an outside hospital with no connection to the VA at all. In the first year of our program, we went on a staggering 823 calls for service. Because of the uniqueness of our program, we were able to help 5 veterans out of state and house 4 of our chronically, severely mentally ill, homeless veterans. In addition to those numbers, we saved 70 veteran lives that were at imminent risk for suicide and could have easily become one of the 17 veteran a day statistics. Now, if you take that 70 veterans a year and multiply that across the amount of VAs, we could potentially reach over 9,000 veterans a year. With suicide prevention being the #1 clinical intervention in VA right now, we can all agree that you can't put a price on a life. And Buying into our program is buying into a life. Thank you.
Excellent presentation.
Thank you.
Very great illustration of some specific examples and the data to support the volume that you've touched with this project. So thank you very much for that.
Thank you.
Can we talk a little bit more about resources? Clarify what the resources and costs are associated with this practice, please.
Sure. So it's 2 FTEs. It's a VA police officer and a VA clinician. You also need to have access to one of the police vehicles. That's going to be to transport the veteran safely, both safety for the employee as well as the veteran. Aside from that, there is some trainings. Depending on your state, there may be certification needed for placing psychiatric holds, as well as some mental health training.
Great. So when you say 2 FTE, 1 clinician, 1 VA police officer, is that 2 FTE dedicated full-time to this effort, or is this done as like an ancillary duty, or?
This is a full-time.
Okay, great. So what kind of feedback have you been getting from the staff who are involved in this practice?
Sure. We've gotten really great positive feedback. We help out our ER as well as our urgent mental health clinic. Suicide prevention, when they're not able to reach the vet and it's that 4th time and sometimes it would get closed out, we're able to now go do a welfare check in the field. We've also been able to assist place holds at the ER if psychiatric providers are busy, so it's decreased the wait time for the veterans to get the mental health treatment.
Great. So what does a long-term sustainment plan look like for a facility?
Sure. Long-term, we'd like to see the program expand to 24 hours a day. We do have a shadow team that kind of assists us in the evening right now with the emergency crisis teams, but we'd like to see it spread to other VAs and have 24/7
Great.
care.
Okay. Any last thoughts that you'd like to share with our audience and the Sharks?
Sure. This program is really important for community engagement. We're also helping our local police officers out in the field. We're able to give them training to help better serve our veterans. We're able to reduce recidivism rates and gain that trust of the veteran. Both my partner and I are veterans, so going out to the home, you can relate to them, and they're able to get that trust and build the confidence to come into the VA. We do follow-up care with all of our veterans, so we will see them while they're on the units and take the time to just really know what their barriers are. And once the immediate crisis is over, we're then able to work with the providers and social workers to decrease those barriers.
Excellent. Thanks a lot.
Thank you.
Thank you, Shannon. Now to our final pitch, I'd like to invite Andrea Hill from Martinsburg VA Medical Center onto the stage. We'll find you.
Veterans were in need of guidance to access benefits and healthcare services. Imagine you are a 30-year-old homeless female veteran, barely 3 weeks sober, with criminal charges pending, estranged from your young child, and you have just shared you were sexually assaulted while serving in the military. What would you do? At Martinsburg, your treatment team would ensure your referral to the military and sexual trauma coordinator, and then you would be scheduled to attend a virtual claims clinic to file for benefits you cannot even begin to imagine you could qualify for. This is the story of Tara, and she was an inpatient in our substance abuse treatment program. On October 26, 2017, she filed for a PTSD due to military sexual trauma during one of our virtual claims clinics. And the experience, and I quote, changed her life 180 degrees. And wouldn't we all like to be able to say that about folks we're working with? Today, she continues her treatment and is service-connected for PTSD. She is also a work study through VA's vocational rehabilitation and employment program. And she plans to get her degree in social work. and has also reestablished her relationship, most importantly, with her child. My name is Andrea Hill, and I'm a Veteran Experience Officer with the Martinsburg VA Medical Center. Welcome, welcome to technology linking care and compassion. The virtual claims clinic provides veterans the opportunity to personally, and I mean personally, access VBA representatives using modern technology from the comfort of their VA Medical Center or community-based outpatient clinic. And we use existing equipment and staff to implement the program. Since its inception in 2015, we have served over 1,400 veterans and have developed a highly, and I mean highly effective and highly adaptable program. So Sharks, who is going to be the first to bid? Thank you.
Thank you, Andrea. So you touched on it lightly, and I just wanted to circle back to it. You talked about the existing staff and resources that you're using, but can you talk about that some more? What exactly is required in terms of resources for this practice?
So I'm going to put a big shout out from the get-go to our telehealth program coordinator and their staff and OINT, because literally it was us approaching them going, hey, you know, we would like to be able to virtually connect our veterans with qualified staff to start working on service claim issues, potentially veteran advocacy questions and the like. And they said yes. Not only yes, but hey, we can get you, we have boxes of cameras. And if you need a second monitor, whatever you need, we have. And that's the beauty of this program. Every medical center, every outpatient clinic in the VA system has full-on access to these resources, and we didn't even need to hire additional FD. As a matter of fact, with the staff that we have to work these clinics, we're growing folks. We're pulling from other services because they have so, I'm telling you, you have to almost be in there to really appreciate when you can work with the veteran with MSC-related issues who've been to hell and back again, and you can journey right alongside with them. It does not take much to get a show of hands who would like to volunteer, learn how to turn on a camera, and make their life real for them again. It's an absolutely moving and incredible experience.
Well put, thank you. I just want to say I appreciate your passion for this practice. Thank you. Also, so what does a sustainment plan look like for this practice as we move forward?
Excellent question, because right now we're in the process of growing our outpatient clinics. And most recently, we have dovetailed Fort Detrick, which is, to the best of our knowledge, the first military and VA-focused virtual claims clinic opportunity. So what we're really looking to grow are not only our internal relationships with our other CBOCs, but also with the military as well. We're pretty excited about that.
Thank you.
Thank you, Andrea. So that concludes our 15 pitches for the day. I would like you all to please join me to give a hand to our 15 finalists here that really put their hearts out there. You all did a fantastic job, and we genuinely appreciate it. Not just your pitch, but all the work you do day in and day out. We also want to thank our 40 Medical Center Sharks and remind you to please put in your bids before 10 a.m. Eastern tomorrow. Also, for all our attendees, you can vote with the Attendify app. Bryn, missing one. Well, we're being told, so if you've got to go under, it's not as intuitive as it could be. You go under schedule, and then Shark Tank event, and then there's a poll, and you vote through the poll. So if it's not there, we will get it fixed. Okay, thank you, Bren. Support team, virtual claims. All right, great. So. We're going to go ahead. The winners will be announced tomorrow at 4:30 p.m. as part of our closing ceremonies. We're going to go ahead and break But just in terms of just general announcement, after this short break for the next hour or so, we're then going to have demos. Demos will take place in here, as well as the Holman Lounge. Also, the Exhibit Center opens tomorrow morning at 8 a.m. And after that, we've got a keynote at 10 and some great special presentations that you're not going to want to miss. And so take a break, and then we have demo sessions here and in the Holman Lounge. Thank you so much. Thanks, everybody.